This is, honestly some fresh off sort of the print data that I'll present today on a randomized controlled trial comparing transrectal with transperineal prostate biopsy. And I'd love to see a show of hands of people here who do transperineal prostate biopsy. And thank you. And so, I'd say less than half. And how many believe that transperineal biopsy is better, whatever better means to you, than a transrectal biopsy? All right, excellent. Yeah, so this will be, I think, of material relevance to the majority of folks here. So a little history before we start, and again, for some of the younger folks here, pre-1980s, prostate biopsy was transperineal. So there's a little bit of a boomerang effect that we've kind of like discussed a couple of times at this meeting. It was digitally guided, so the operator would put a finger in the rectum, feel where the prostate was, and then through the perineum, just jab a needle, honestly, blindly into the prostate and do the biopsy that way. Of course, in the 1980s, ultrasound became a tangible imaging modality. There was a little bit of a turf battle between radiologists and urologists, and clearly urologists won that turf battle, so there's some historic relevance to us being able to do transrectal ultrasound and make it a urology procedure. And I would say transrectal ultrasound guided biopsy became the standard of care with direction into the peripheral zone because of the emerging data that most of prostate cancer emerges or arises in the peripheral zone of the prostate, and that is the zone closest to the rectum, right? Accuracy and tolerability improved. People became very skilled at doing this, and so did cancer detection rates, of course. PSA screening kind of came around in the 1990s, and several problems, I'd say, emerged out of this issue of how well or how we were doing prostate biopsy. One is risk of infectious complications increased. This was a transrectal procedure, and we were putting needles through the rectum. We've also been using and abusing antibiotics through the decades, and our antibiograms in our local environments show significant resistance to several organisms that may be relevant in prostate biopsy. So prevalence of resistant bacteria in the population increases, but so did over-detection and treatment of indolent tumors, which is another potential problem with how we do biopsy, is that we want to, the goal of a biopsy is to do it safely, to do it with the most sort of comfort to the patient, but also to detect what's relevant and to not detect what's irrelevant. And if you believe this data, 30-day admission rates post-biopsy per SEER Medicare were as high as approximately 7%, data published by Stacy Loeb. And solutions, of course, started to emerge to these problems. Broadly speaking, we started to use augmented antibiotics or antimicrobials in our practices, and that is to use big gun antibiotics for a prostate biopsy. Let's just give them a big dose of this and a dose of that, and we'll just do the biopsy, and that'll solve the problem. Also, rectal swab cultures became a thing, and at Hopkins we were very much in that camp rather than the augmented antibiotics. So you do a rectal swab in clinic, it added logistics, you had to have an infrastructure to be able to send the rectal swab out, get it back in a few days to say there is fluoroquinolone resistance or there wasn't, and kind of give you a little sense of what antibiotic to use, and then hopefully an oral antibiotic, because that adds logistics to give IM or IV. People published and talked about betadine enemas, so cleaning the rectal vault, so in addition to sort of an enema, to do some antiseptic kind of cleansing of the rectal vault through betadine enemas before you do the biopsy. And then there's also some discussion in the literature about needle handling and cleansing, so putting the needle through the rectum, and then when you take it out, cleansing the needle to put it back in. And some people believe that dipping it in formalin to sort of let the specimen get out, the formalin itself would sort of like sterilize the needle or what have you. So those are concepts that developed as solutions. The AUA took this, of course, very seriously, and in 2014, the AUA Quality Improvement Summit made some recommendations to urologists, and that is that we need to establish biopsy protocols that are followed in our practices, and we have to evaluate and report infection rates quarterly, regularly. Of course, we need to all be aware of our local antibiogram prior to the prescription of antibiotics, and to just kind of go with, we are going to use Cipro because that's just sort of what John Davis uses, maybe would not be correct, because your local environment can be different. And for us who are at tertiary care centers, our local environments are somewhat irrelevant because people travel, and so their local antibiograms become relevant as well. And identifying patients at increased risk is important. So we probably as healthcare providers are at increased risk, just working in hospitals and being around antibiotics and things like that. But in general, people who've had recent antimicrobial or repetitive antimicrobial use, whether it's for a dermatologic condition, or whether it's for another infection, international travel changes, rectal, vault flora potentially. And for patients who've had previous biopsy, this may be relevant as they've had prior doses of antibiotics. And of course, the AUA Quality sort of Summit recommended either rectal swab or augmented antibiotics for the high-risk patients, at least for the high-risk patients. Studies, then looked at the time, transperineal was being performed. It was being performed differently than I think how we do it today. But in any case, there was a literature on transperineal, a lot of it from Europe, to be honest, and then there was a transrectal literature, ultrasound guided, mainly from the United States, and looking at sort of pooled prospective databases and looking at infection rates. The sort of consensus in historic literature was transrectal was associated with a higher infection rate than transperineal. And the rate of sepsis from published series on transperineal biopsy really kind of approached zero. So the question is, do these strategies work? What we outlined and what the AUA kind of Quality Summit said, and I'd say yes, but there are some caveats. Augmented prophylaxis is poor antibiotic stewardship and will likely lead to more resistance, right? If everybody who comes through is getting, Vanc, Gent, whatever, we're just going to breed resistance to those antibiotics, and we should be good antibiotic stewards. Rectal swabs are a logistical nightmare for most practices, I would say, and many patients, based on rectal swab data, will still need big gun antibiotics potentially. And then there's the issue of cancer detection. Active surveillance is now a main treatment option for patients with very low risk and low risk prostate cancer, and this requires repeat biopsies, so very relevant to this population of repeated biopsies and infection there, picking up insignificant cancers. And then there's the concept of missing the anterior tumors, which we find happens in sort of all people, but there is maybe some literature that it may be more prevalent in men of African genetic ancestry, that the tumors tend to be a little bit more anterior, and perhaps a transrectal approach from an angle standpoint is hard to target that notorious anterior area where some cancers can hide. And this slide kind of demonstrates the geometry that may be poorly accessed by transrectal ultrasound. And so, this sets the stage for, we've done transrectal ultrasound biopsies, the standard of care. Some problems emerge, infections, superbugs, augmented antibiotics, detecting too many Gleason 6s, not detecting the anterior tumors. So is transperineal sort of the answer? And much of the literature historically had been on transperineal template biopsies, right? So these were the saturation biopsies, or you put a brachytherapy grid and you would get your biopsy through there. Not many folks were doing freehand, ultrasound guided perineal biopsy. And there's some issues with the template sort of approach. And it requires, in general anesthesia, because there's multiple pokes of the perineum. It's hard to get like a really good block of the entire perineum. Historically, it was done in the saturation sort of realm for the most part in the United States. So it was because you were going to get a lot of biopsies. So it required general anesthesia. which would decrease your throughput for all the people. If you needed to do it on every patient, that just seems like we do a lot less biopsies because just the throughput would be limited. It's expensive. You had to buy the brachytherapy grid, which costs a little over $100,000, and cannot be performed sort of in the office. And there's a complexity to it. So a few years ago, the concept of in-office transperineal biopsy with local anesthesia was popularized, and I would say mainly by the appearance of the Precision Point on the market. This is Matt Alloway's company from actually not too far from Baltimore, Western Maryland, in Cumberland, close to where Dr. Kane kind of works. And this device is a disposable device. It's not the only way to do a freehand local anesthesia biopsy, but it certainly makes it easy. You can see there's a stage, a needle with some apertures, and you can kind of decide which aperture to put the needle in to sort of get a more anterior or a more posterior biopsy. And when assembled, it looks like what's shown on the slides there. There are some non-disposable versions of this, and I think we're going to see more and more products come up on the market. So it's not the only sort of product, but essentially, you could do this in the office. Patient's placed in the lithotomy position. The scrotum is kind of retracted out of the way to sort of expose the perineum. And then the idea would be that the ultrasound probe obviously still goes into the rectum, and we then use one needle poke on each side, and then we use that one needle poke kind of like the scruff of a dog to take that and direct it wherever we want it into the prostate. So it's one puncture on each side after a good local block. And the template that I use, and again, we can debate templates, but this is a fairly standard template. We published, Alexa Meyer, one of our residents, published this in 2018, and it seems to do the job. So the idea would be anterior biopsies, far lateral biopsies, and then posterior biopsies. Because this is transperineal, you're going to come in kind of from the apex, and in a large prostate, you start to, if you really want to kind of sample, you may do apical biopsies and base biopsies because the needle isn't going to sort of traverse. But what you get are these really nice cores, and if you're in the peripheral zone, the entire core is peripheral zone, as opposed to when you go through the rectum, it'll shoot up and get the peripheral zone and then maybe some of the transition zone or what have you, theoretically speaking, right? It does require some infrastructure, so there's the disposables, that's the Precision Point, and then you do need a side-fire ultrasound probe as opposed to an end-fire probe, which is what we typically use for transrectal ultrasound-guided biopsies. And what's nice about these side-fire biplanar probes is you can get really two views at once. You can get the sagittal view and the transverse view, and you can put them side by side, or you can toggle between them. And as you can see, as you direct the needle through the perineum, you could see the needle enter the peripheral zone there. I would say this is the anterior portion of the peripheral zone, but still peripheral zone. And you could see it on two planes, confirm where you are kind of at all times. And anterior biopsies are really no problem. You can also confirm kind of where you are there. So adoption of transperineal ultrasound in the office setting, I think has occurred. We saw by sort of the show of hands here that many of you have sort of maybe are doing these transperineal biopsies. I'd say we sort of drank the Kool-Aid, and over the last few years have changed so that all of our biopsies, I'd say the vast majority, are done using transperineal in a sort of an office setting, awake, using sort of this approach. But clearly, because of a controversy on whether what we're doing, the added expense logistics, is this any better than the transrectal ultrasound and guided biopsy, and what are the sort of differences? And the only way to answer questions in medicine, I think, are through using science and not anecdotes. So I can come and tell you we can get better anterior biopsies. It's a juicy core that is all peripheral zone, all the sort of niceties that come with a transperineal biopsy. But in reality, does it hold when we actually compare it to transrectal ultrasound guided biopsy? So there's been 2 now randomized controlled trials, one done by Badar Mian, who's at Albany, and that was a single institution randomized trial, many patients, and I'll review those results. And then we, Jim Hugh, who's at Cornell, Ted Schaefer at Northwestern, and I are PIs, and this was an NIH R01 funded trial that just completed to answer that question. And we called it the PREVENT randomized trial. And the specific aims of this trial were to compare adverse events following in-office transperineal versus transrectal MRI-guided biopsy, and to compare basically infection rates and bleeding complications and urinary retention in the 2 arms. And this was in patients who were biopsy naive. So importantly, these are patients who've never had a biopsy before. So these aren't your active surveillance patients. And to also compare pain and discomfort, because if you're going to knock transperineal, you'd say it's maybe more painful than putting a needle through the rectum. So we looked at that. And then, of course, specific aim 3 was to compare detection of prostate cancer with the hypothesis that transperineal would detect more significant cancer than a transrectal. These were all, as you'll see from the study cohort, and I don't know if this, it actually projects reasonably well. They were well matched. Most of the patients had a PIRADS 3, 4, or 5 lesion. Most of the patients, the vast majority, had an MRI, and these were done either with a fusion modality, Coelis, Urinav, what have you, and cognitive fusion was also allowed in this trial. But whether it's transrectal or transperineal, there had to be some documentation of a fusion, and I'd say there's some cognitive fusions in the transperineal, very little cognitive fusion in the transrectal, but there were fusion biopsies done here. And you see that the number of systematic cores was well matched between the 2, and on average 3 biopsies per target were obtained here. So here's the sort of results. There were 0 infections in the transperineal, and it's important to note that the transperineal biopsies performed in this trial were done with no antibiotics, so just cleansing of the perineum with just chlorhexidine or what have you, whereas the transrectal arm did have pre-procedural antimicrobials, and both rectal swab or augmented antibiotics were allowed, so depending on sort of the local practice of that. So it's very important. So with no antibiotic, transperineal had 0 biopsies, and with antibiotics, there were 4 infections in the transrectal. The difference wasn't statistically significant, so make what you want out of that. There was 1 urinary retention in the transperineal group, 3 in the transrectal, also not significant. 1 bleeding complication in the transrectal. I think we've all been in clinic, putting a tampon in the rectum to sort of calm down. But this actually required an intervention. 1 in the transrectal, none in the transperineal, also not clinically significant. And then interestingly, if we were to call clinically significant cancer grade 2 and above, so 7 and above, there was also no difference in the detection rate between the 2 approaches. If you looked at these pain scores, and this is a score from 1 to 10, you'll find that transperineal approach was associated with slightly higher pain scores, and it quickly resolves and kind of equals that of transrectal. It's hard to tell, a 3.6 versus a 3.0, what that means in actually clinical implications on the patient. So, you could also interpret that in, I think, many ways. And so, I would say at the end of the day, this was a fairly negative trial, and perhaps there's something in it for everybody. If you want to do transperineal, you can probably use the data here to justify transperineal. And if you're old school and you're doing transrectal, you probably could find enough data here to justify the approach without feeling too bad about it. There's going to be some subset analyses of anterior lesions, et cetera, to sort of further delve into the cancer detection question, because this is for all comers, and we define clinically significant cancer with a very sort of wide net of 3+4, 7 and above. To put our trial next to Better's trial, which the one done in Albany, a couple of differences. They had more, white patients. I don't know if that matters. The biopsy indication, we were first-time biopsy. They included second-time and third-time biopsies. They included 3 urologists. Ours was 24 urologists, but the bulk of the cases were done probably by a subset of a smaller number, but it was multi-institutional. They were both randomized, and we used no antibiotics versus a targeted approach with rectal swab and augmented. They used augmented. And in their trial, they did have a 2.7% infection rate with transperineal, and we saw a 0% infection rate. They saw a little bit more in their transrectal. And the infection definition was slightly different. But I think they were fairly similar trials, and they're both negative trials. So I would say, in my sort of opinion, will I stop advocating for transperineal? No, I mean, I think this has become sort of how we do it. I think that there's some potential tangible benefits, but if somebody wants to do transrectal, I think it's perfectly fine, and I think the data will support that. So maybe don't believe the hype. Yep, thank you.